All right, next paper is Precocious Rupture of Abdominal Aortic Aneurysms Below the Size Criteria for Repair, Risk Factors and Outcomes. The paper is from Stanford and University Hospitals of Cleveland, presented by Dr. George.
Thank you for the opportunity to present our work looking at precocious rupture of AAAs. I have no financial conflicts of interest, and the views expressed in this talk are those of the authors only and do not represent those of the VA or the U.S. government. There is general agreement that small aneurysms less than 4 centimeters in maximum diameter are at low risk of rupture and should be monitored, whereas an aneurysm greater than or equal to 5.5 centimeters in men or 5 centimeters in women should be repaired in an otherwise healthy patient. But some controversy has existed regarding treatment strategies for middle-of-the-road patients who present with a AAA between 4 and 5.4 centimeters. More or less 2 decades ago in the UK small aneurysm trial and the US ATOM trial, the 30-day operative mortality disadvantaged the immediate surgery groups. Long-term, there was statistically significant difference in survival between the immediate repair and surveillance groups, arguing against immediate repair for aneurysms of this size. In more recent times, nearly 80% of AAAs are treated with EVAR, and given the less invasive nature of EVAR, 2 studies in the late 2000s reevaluated the appropriateness of intervention for small aneurysms. The CSAR and pivotal trials compared immediate EVAR with surveillance for small AAAs and found no survival benefit for early EVAR, but neither trial was designed to determine whether immediate EVAR might be beneficial or harmful for specific AAA size ranges or age subgroups. A Cochrane review of these 4 studies confirmed no advantage to immediate repair by open surgery or EVAR for small AAAs. But that's not to say that patients don't rupture at smaller diameters. In fact, we know from experience and from the literature that they do. A statement from the Joint Council of the American Association for Vascular Surgery and the SVS estimated the annual risk of rupture of aneurysms between 4 and 5.4 centimeters to be anywhere between 0.5 and 5%. Although it's just a statistic, 5% of the patients that rupture early feel 100% of those consequences. But how do we know who those patients will be? And what happens to them when they do rupture? Our goal was to identify risk factors for precocious AAA rupture between or below the published SVS guidelines recommended threshold for elective repair and compare 1-year outcomes following ruptured AAA repair above versus below the size criteria for elective repair. The Vascular Quality Initiative was queried between 2013 and 2019 for patients undergoing repair for ruptured AAA, and we divided the cohort based on diameter into small and large AAA subgroups, with small being defined as less than 5 centimeters for women and less than 5.5 centimeters for men at the time of rupture. Stratifying by ruptured AAA diameter, we performed univariate analysis evaluating demographics and comorbidities, and an adjusted Kaplan-Meier analysis comparing overall survival, aneurysm-related mortality, and reintervention at 12 months. Over 5,000 ruptured AAAs were repaired at VQI centers during the 7-year study period. More than 1 in 10 ruptures occurred at diameters less than the guideline recommended threshold for elective repair. As some food for thought, only 34% of patients in this VQI cohort who presented with a ruptured AAA were eligible for AAA screening by USPSTF criteria, and only 58% of patients were eligible for screening by SVS criteria, which is not surprisingly lower than the elective population of screening eligibility of about 65%. Looking at demographics and comorbidities, small ruptured AAA patients were slightly younger, less likely to be white, less likely to be transferred from an outside hospital, but more likely to have hypertension, diabetes, and ESRD, and be prescribed antiplatelet or statin therapy. Summarized another way, patients who ruptured at smaller diameters were slightly younger, non-white hypertensive diabetics with end-stage renal disease who lived near a VQI center. It's worth noting that overall, optimal medical therapy prescription was poor, well below half in this cohort of patients who presented ruptured. With the exception of the largest AAAs, women were significantly more likely to rupture at smaller diameters compared to men. This was true particularly below a 5.5 centimeter cutoff, but women were not more likely than men to rupture below the SVS sex-specific thresholds for repair. Ruptured AAA patients were significantly more likely to be repaired by EVAR. Ruptured small AAA patients also had significantly lower in-hospital mortality at 18% versus 28% compared to large AAAs, and this was largely driven by the EVAR approach. There were also significantly fewer perioperative complications across all major organ systems for patients who ruptured at smaller AAA diameters. On Kaplan-Meier analysis at 12 months, small ruptured AAA patients represented by the dashed line in purple and labeled in purple had significantly better overall survival. Small ruptured AAA patients also had greater freedom from aneurysm-related mortality at 12 months. And small ruptured AAA patients had a significantly lower rate of reintervention or reoperation compared to patients who ruptured at larger diameters. In a post-hoc analysis, stratified by operative approach, with open being on the graphs on the top and EVAR being the data represented on the bottom, we found that the better overall survival, freedom from aneurysm-related mortality, and freedom from reintervention that patients with small ruptured AAAs experienced was largely driven by the operative approach and being repaired by EVAR. As I wind down, this study does have some limitations, namely that as a VQI study, we are limited by the generalizability of these results. We also don't know whether patients were aware of their aneurysms at the time of rupture and what their prior interaction with the healthcare system was. And we also don't have the benefit of the longer Medicare follow-up of the VQI vision data sets in this particular study. Our takeaway points from the study are that patients with small ruptured AAAs experience lower in-hospital mortality and morbidity and improved one-year survival compared to patients who ruptured at diameters meeting size criteria for elective repair. We also noted that EVAR was associated with better outcomes than open repair for patients with small ruptured AAAs. And finally, we found that women ruptured at smaller diameters more often than men. Given contemporary elective outcomes for women, perhaps the size threshold for repair should be reevaluated and perhaps even lowered. For future directions, in addition to doing a subgroup analysis stratified by sex for the manuscript to provide evidence to my last proposal, it's nice to be able to say in a future direction slide that not only is more research needed on this topic, but more research is coming in the form of the Warriors trial. There's a great summary in the September 2022 Vascular Specialist, but in brief, the Warriors trial is an upcoming RCT headed by the Imperial College of London, which aims to answer should women have their aneurysms repaired electively using EVAR at smaller diameters compared to men in order to improve their survival and quality of life. I'm optimistic that evidence-based recommendations for managing a generally understudied patient population are coming. Thank you again for the opportunity to present our work, which was completed as part of a Stanford-Cleveland Clinic collaboration. I'd be happy to take any questions.
Hello. Thank you for your presentation and for taking an interest in this. I think we all would like to know more those factors that lead to precocious rupture to prevent it. When listening to your introduction, I thought that you were going to present about finding those factors that predisposed to precocious rupture, and I'm not sure that this choice of comparison helps us know that question. Isn't the appropriate comparison between patients who ruptured and patients who didn't rupture with small aneurysms?
That is a very appropriate question. Using the VQI procedural data set, we only have those who ruptured in terms of comparing those large versus small. I think a better data set ultimately to answer your question would be something using Medicare data set or even using AI and NLP to really get at what those risk factors are to have the appropriate counterfactual, which is those who don't rupture at smaller diameters. So a very excellent point in terms of study design, but the VQI as a procedural data set is limited in that respect.
Nicely presented, Matthew Worcester from MUSC. One question and one comment for you. First, do you have any morphology data at all to comment on whether these were saccular PAUs versus fusiform aneurysms versus potentially even mycotic aneurysms? And then the comment is a word of caution. Please don't let the New York Times pick up your publication with the headline, "Small aneurysms, the ticking time bomb, vascular surgeons refuse to treat, see your cardiologist."
Thank you for the warning. In terms of the morphology, that was something we will ensure that we include as part of the manuscript in terms of the kind of predisposing risk factors from a morphologic standpoint. We were looking more at the kind of the comorbidities and things you could diagnose just by doing chart review as part of the VQI data sets. But yes, morphology as we take in each patient, treat each patient as an individual is going to be an important factor in terms of who we treat more aggressively at smaller size.
Yeah, thanks. Very well presented. And I think the topic is very important. I'm not sure this is the right data set to answer the questions, but certainly is a first good initial step to raise awareness and lead us down the path of what are the better questions to ask. I think one other part here to remember is this is biased by these are the people who were repaired. What about those who ruptured and did not get repair? And certainly one may argue a large aneurysm that's ruptured in an elderly person versus a small aneurysm in a younger person that's healthier, there's going to be a discrepancy in who even gets into the data set. So just to address that discrepancy in your manuscript. The VQI does have a little bit of morphological data, specifically anatomic data with regards to the neck. And one may surmise that a smaller aneurysm potentially has a more favorable neck anatomy that could explain some of these outcomes. Were you able to discern whether that played into the difference in outcomes in this data set?
We did not look at that yet, but I think that's a great addition to the manuscript in terms of looking at the neck size, in terms of suitability for, or what particularly about these smaller aneurysms made them suitable for EVAR in order to be able to then derive those improved outcomes.
Dr. George, I think this was a great study. I think that you guys really looked into something that is necessary. I do agree that while there is a lot of benefit to comparing those who haven't ruptured to those who have ruptured, I also think that there is some merit, like you guys were doing, to look at those who didn't rupture early on but kind of grew to a size where they ruptured, whereas others ruptured early on, even though their overall transverse diameter size was small. So we in our group actually were spurred by some anecdotal findings to do a very similar study in which we looked at the rupture rates of those who were small and large. But we were anecdotally spurred to do this because of looking at people's access to care. And we noticed that people who ruptured at an earlier rate had significantly higher deprivation, whether you measured that by DCI or by area deprivation index. I would love for you guys to apply that to this VQI data set, maybe with vision, to be able to see if you can really tease out this access to care. I mean, our study was only in Pittsburgh, in that greater Pittsburgh region, and I would love to see if you could do that nationally.
That's a really great point, Dr. Lang, and you can sort of see that in terms of the kind of limited access to care using sort of prescription of antiplatelet and statin therapy as a kind of poor surrogate in this case. But yes, that's a phenomenal idea. Thank you.
One last question.
Yeah, just to echo the thought-provoking presentation and really excellent analysis. My question was, within the spectrum of sizes, did you find that there was an absolute cutoff for men and women, that you found no ruptured aneurysms below a certain size? For example, were a lot of these patients that ruptured, in women 4'8", 4'9", that just sort of kind of grouped in that, or did you find that some were 4.1 or 4.2? Did you look at kind of subgroup analyses of the actual sizes?
We did. When we compared the both kind of male and female by sort of binned into kind of 4 to 4.5, 4.6 to 5, we did find that there were still patients, about 2% of women, about 4% of men, still rupturing at those smaller diameters. But we did not incorporate that into the analysis.
But did you find
itself.
A threshold where there were no ruptures below a certain size?
So there were still even ruptures even below, at least in the VQI data set, below 4 centimeters. So to the other point made earlier in terms of morphologic data, it'll be important to take a look at those patients to see what was more unique about those aneurysms that ruptured. But yeah, even still below, less than 4.5, there are still aneurysms that were rupturing.
Interesting. Thank you.
Okay, thanks.